Visionary care and visionary careers start at Eye Care Partners. We believe every person deserves the best eye care possible and that together we bring the absolute best to communities across the U.S. Learn more at eyecare-partners.com.
Welcome to the Pupil Pod, where we use clinical cases to guide discussions on board review topics. I'm your host, Ogul Uner, and my guest today is Dr. John Chen. Dr. Chen is a neuro-ophthalmologist and professor of ophthalmology and neurology at the Mayo Clinic in Rochester, Minnesota, and I'm so excited to have him on the podcast today. Dr. Chen, thank you for joining me.
Well, thanks so much for the invitation. Really excited to chat.
Let's dive right into our case. We have a 32-year-old female who presents with decreased vision in the right eye and pain for 1 week. She reports a history of numbness in the right arm a year ago that's self-resolved. On exam, her best corrected visual acuity is 20/50 in that affected right eye and 20/20 in the left eye, with a right relative afferent pupillary defect. Your color plate testing shows 2 out of 14 in the right eye and 14 out of 14 in the left eye with Ishihara, and a dilated eye exam in both eyes is unremarkable. Dr. Chen, what are your initial thoughts about this case and what additional information would you like to know?
Well, in a young female who presents this way with pain, eye pain, decreased vision, RAPD, and a normal fundus exam, I'm already thinking most likely a retrobulbar optic neuritis, the most common. It sounds like she's got eye pain. I'd want to know is the pain worse with eye movements? I'd want to know if she had any other neurologic symptoms in the past, a little bit more details about, I think it sounded like some numbness in the past. So I'm already thinking about optic neuritis or retrobulbar process, and that'll lead to my workup, which will be an MRI of the brain in orbits to confirm the suspicion. And then we're going to have to try and figure out what caused the optic neuritis. But I think I would start there and then let the workup kind of guide my thoughts.
Awesome. And as you said, it's very important to take a thorough medical history. And so they don't have no medical history. They deny any other neurological symptoms besides the transient numbness that we mentioned. You do obtain a visual field on the same day that you have access to. It does show a central scotoma in the right eye and is normal in the left eye. And your MRI does show enhancement of the intracanalicular portion of the right optic nerve and a few T2 flare hyperintense lesions in the brain without enhancement. So what are your thoughts at this point?
Yeah, so the enhancement of the optic nerve really kind of helps confirm the suspicion of optic neuritis. And again, that's highest on the differential diagnosis. And then now etiology. So 50% of optic neuritis is multiple sclerosis. And I guess one of the questions is, what is the ethnicity of this patient?
This patient is Caucasian.
Okay. And again, it's 50% in Caucasians, it's MS. And then other ethnicities like Black and Asians, actually NMO can sometimes be more common than MS. So here again, we're thinking possibly MS. It sounds like there's some white matter lesions. Are they periventricular in location?
Good question. Some of them are periventricular and some of them are in other locations.
Got it. And again, suggestive of multiple sclerosis. With the numbness in the past, it sounds like that might have been a transverse myelitis attack. So I think we'd want an MRI of the spine as well, cervical and thoracic, looking for prior lesions to kind of help confirm our suspicion of multiple sclerosis.
I think you hit on the big points we talked about, this being likely like a typical or an MS associated optic neuritis. You mentioned NMO and other atypical optic neuritis etiologies, so it's important for us to get a demyelinating panel and then additional MRI imaging of the cervical and thoracic spine, like you mentioned. And ideally a neurology consult and the discussion with IV steroids that we'll talk about later. But before we do that, what is your clinical approach for a patient you suspect has optic neuritis? What is the typical presentation and findings that you might see in clinic?
90% have pain with eye movement, so that's a tip-off that it's going to be optic neuritis as opposed to something like ischemic optic neuropathy, which will be painless. The demographics kind of help guide you a little bit. If, a 33-year-old female, you're definitely gonna be leaning toward optic neuritis. They come in and they're a 76-year-old male, maybe it might be more ischemic, in terms of your differential diagnosis. But that pain kind of makes you lean more toward optic neuritis. A couple other things that kind of make you think that way is actually the vision loss in terms of how fast it happens. With optic neuritis, it tends to be more subacute, tends to worsen over 2 to 7 days, whereas ischemic optic neuropathy, it'd be just really all of a sudden, vision loss, painless. And then the fundus exam, that's another big one. Again, if there's disc edema, that could be non-arteritic anterior ischemic optic neuropathy. With optic neuritis, 2/3 of the time it's retrobulbar and there's no disc edema. So all those things are making me lean toward optic neuritis. This patient's stem just really was screaming optic neuritis in all the classic ways. And then the workup is, again, the MRI brain and orbits. The orbits are important to confirm the optic neuritis, showing enhancement of the optic nerve. The brain to look for lesions suggestive of multiple sclerosis or other demyelinating disease. And then the MRI orbits is also important in helping determine the etiology of the optic neuritis, because MS, the optic nerve enhancement, the inflammation tends to be a pretty small segment. And then some of these atypical causes of optic neuritis, like NMO and MOG, antibody-associated disease, they tend to cause longer segments of enhancement of the optic nerve. And with MOG, antibody-associated disease, or MOGAD, it tends to cause profound enhancement, so much more that it spills into the periorbital fat. And a lot of times these patients with MOGAD optic neuritis will have disc edema on examination. But this patient was really sounding more like your typical MS optic neuritis, the mild vision loss, unilateral, um, and then, of course, had the preventricular white matter lesions on MRI.
I think, as you mentioned, uh, the history can sometimes point to different etiologies, like a prodromal viral illness can sometimes be present in these patients. The classic teaching is that they may have more symptoms when the body temperature rises, like if they're doing exercise or bathing, we call the Uthoff phenomenon, or an altered perception of motion. If they've had a prior episode of optic neuritis before, what we call the Pulfric phenomenon, they may see some altered perception. So all of those can also be certain clinical or historic findings to ask the patient. And you, I think, talked really in detail about the clinical workup once you perform the exam and the ancillary imaging, proceeding with MRI. Do you tend to recommend proceeding to the emergency room to get the MRI? And do you get spinal imaging on every patient?
That's a good question. I think it kind of depends on how quickly you can get the MRI and how bad the vision is. With this patient, they're 20/50, so not horrible vision. And if you can get an MRI in the next couple of days as an outpatient, I would probably actually just work this patient up as an outpatient, because it's interesting. Again, I'm leaning toward this being a typical MS optic neuritis. And the optic neuritis treatment trial actually taught us that patients can be treated with IV steroids and they have faster recovery, but it actually doesn't change the ultimate outcome. And so whether you rush them to the ED and get IV steroids and MRI that night, or you get the MRI in a couple of days, it really doesn't matter, because again, those IV steroids, it's all about faster recovery, not change the ultimate outcome. It'd be a little bit different if the patient comes in and their light perception, vision. Then I'm more worried about these atypical causes of optic neuritis like NMO and MOG, and some of those, time may be of the essence, and we're going to be treating them with IV steroids right away. Those patients I probably do send to the ED just so we can get faster imaging, faster treatment. The other question you had about the spinal imaging, I do tend to get spinal imaging on the bulk of my patients, especially if I'm thinking MS, but I think it's helpful in some of these other etiologies as well, because you could always be surprised and find some lesions that will make you think about more of a systemic disease. So we do usually get some baseline imaging, MRI, cervical and thoracic spine.
It's also important to note that a lot of disability that's associated with MS is due to spinal lesions. And so detecting those may also help our neurology colleagues and really finalize the diagnosis. I love that you talked about the treatment for the optic neuritis treatment trial, that the IV doses speed recovery, but not the final outcome, and that patients receiving just regular dose oral steroids alone experience twice as high recurrence rate. So we do not use those anymore. I know there are some cases where people will use ultra high dose oral steroids in some patients if they cannot get them into the emergency room. Um, do you employ a typical strategy?
It's a good question. It is very interesting that the optic neuritis treatment trial found that oral prednisone really didn't help, and like you said, actually somehow potentially increased the risk of relapse optic neuritis. So that's not typically something that we recommend. But what recent studies have suggested is it's not really the route, oral versus IV, it's really the dose. And so if you give them whopping doses of oral prednisone, equivalent to what you get through IV, that's 1,250 milligrams of prednisone equals 1,000 milligrams of IV methylprednisolone. If you give that amount of dose, it's really equivalent. And so really you could do either one. The only drawback about the oral prednisone is that the largest prednisone tablet is 50 milligrams. So you actually have to give them 25 50 milligram tablets to equate what you get through the IV. So we do that. Again, if the patient doesn't want to come to the ED or an infusion center for IV. But again, it's 25 tablets they've got to take all at once for 3 to 5 days. So you definitely want to give them some omeprazole or something for the acid reflux that's invariably going to happen with that many pills.
Yeah, that's a lot. It's a lot to put on the patient for sure. And what is the visual prognosis of patients with typical optic neuritis?
Fortunately, the visual prognosis is pretty good. I would say I kind of tell my patients 90% of patients are going to get 90% of their vision back. The ONTT, the optic neuritis treatment trial, predominantly had typical optic neuritis. And again, the majority of patients had a pretty good amount of visual recovery. But some patients still do poorly, especially the ones that present with poor vision at onset. In the ONTT, 3% of patients still ended up 22 and or worse. So again, if they present with very severe vision loss, I do treat them pretty aggressively with IV steroids. And then if we're suspicious of an atypical optic neuritis, so if we treat them with 5 days of IV steroids and they still have very poor vision, like light perception kind of vision, we actually often escalate to a treatment called plasma exchange. And with plasma exchange, they often require a central line, and during this procedure, we essentially take their plasma, their serum, remove the pathologic antibodies, and then give them plasma back. So again, washing out those pathologic antibodies, pathologic cytokines, and we think that helps with especially aquaporin 4 NMO optic neuritis. But we'll do it for severe optic neuritis that doesn't respond to corticosteroids.
I think that was a great summary of both the ONTT and then the typical optic neuritis treatments. I think it's also important to keep in mind that uh, the recurrence rate per the ONTT was about 30% in 5 years. It was higher in patients with multiple sclerosis. And then one thing that really comes up in testing is the MS risk that the ONTT showed. So if you had no MRI, and you didn't really have more information that apart from the fact that this patient had optic neuritis, they kind of said it's about 50% in 15 years. Now, if they didn't have any lesions, that can be as low as 25%, or if they had at least one lesion, it's about 72%. So in my mind, I always think 25, 50, 75 in 15 years, and those numbers get frequently tested. So I just wanted to include that as well.
I agree. I think that's super important. It's one of the best things the ONTT taught us. Again, we thought that steroids would help, and it just found that it just quickened recovery. But they had this cohort of patients that they followed for 15 years, and so it was a really great study to determine that risk. And again, your patient who has optic neuritis, the first thing on their mind, they're going to ask Dr. Google or look on the internet. The first thing they're going to see is MS, so they're going to want to know what is my risk of MS, and this ONTT kind of provide that information for them. And again, bear in mind that's going to be predominantly for Caucasian patients. If it's a Black patient, an Asian patient, risk is probably going to be lower, but then you've got higher risks of some of these atypical causes of optic neuritis like NMO.
And that's a great segue to talk about atypical optic neuritis. So, Let's transition to that topic, starting with antibody-mediated processes. You mentioned the importance of a serum demyelinating panel, and we've been talking about different diseases in addition to the typical MS. Could you talk more about the demyelinating panel and the entities that it's testing for?
Yeah, that's been a really large change, especially over the past decade or so. So we've known about neuromyelitis optica, NMO, for essentially a century. Used to be called Defect disease, since Dr. Defect was the first one to describe it. But now, in 2004, essentially, we identified a biomarker. Essentially, it's an antibody against aquaporin 4, which is a biomarker and pathologic cause of NMO. And so now we actually have ways of detecting these patients. These patients with NMO have very, very severe optic neuritis. They can have severe transverse myelitis that kind of puts them in wheelchairs, really severe inflammation, much more than MS. And 90% of patients with NMO have relapsing disease, so they all have to be on chronic immunotherapy. And so anytime you've got a patient with optic neuritis, we should be checking for aquaporin 4 antibodies, because it's an incredibly specific antibody. There's essentially no false positives, and that can make your clinching diagnosis. More recently, since it's just been about a decade now, we have a new entity called MOG antibody-associated disease, or MOGAD. There are biomarkers, antibodies against MOG, myelin oligodendrocyte glycoprotein. These patients tend to present also with inflammation in the brain. Their optic neuritis tends to be quite severe at onset, but fortunately, they tend to recover much better with steroids. A couple other features of them is they tend to be bilateral about 50% of the time. They tend to have more disc edema, whereas typical optic neuritis and NMO, only a third have disc edema. It tends to be mild. With MOG, it's about 80% have disc edema and about 50% have pretty severe disc edema. So if you've got an optic neuritis and there's a lot of disc edema, you want to start thinking about that. Tend to have a good amount of pain. But the good, and then on MRI, like we talked about, tends to have rip-roaring enhancement of the optic nerve. So it looks really bad, but fortunately, when you get treatment with steroids, it tends to melt away pretty good. So again, now if we've got a patient with optic neuritis, obviously I'm thinking MS, but we do get the CNS demyelinating panel pretty much on all patients, and that's going to be your aquaporin 4 antibodies, your MOG antibodies. The only time I might not consider getting that is if a patient has had like the most classic features of MS with Dawson fingers, positive liquid conal bands on lumbar puncture, short segments of inflammation on the MRI of the spine, mild optic neuritis. That's just screaming MS optic neuritis. You might not need to get the antibodies, because you can sometimes get false positive MOG antibodies. So I'd still probably get aquaporin 4 antibodies. Might hold off on the MOG antibodies on those, but you couldn't go wrong if you just get NMO and MOG antibodies on every single optic neuritis. No one would fault you. But if you didn't get them, they could fault you, because again, if you had an optic neuritis and it was NMO and you're lucky and you didn't check, and they were lucky enough to get recovery, and then they have another attack and now they're in the wheelchair the rest of your life, you could have been that person who diagnosed NMO with that first optic neuritis attack and prevented them from having permanent disability the rest of their life.
I think those are really important points. And, you touched upon a variety of different clinical aspects that may differentiate the two. For NMO, you talked about myelitis symptoms, the profound vision loss. Sometimes hiccups can be specific because they can get area postrema syndrome. And then for MOG, you did mention this, prominent disc edema, bilateral optic neuritis. Sometimes a history of ADEM may also be featured, that tends to be this disseminated encephalomyelitis, in children. And you did talk about the longitudinal extensive enhancement on MRI and the myelitis and these atypical lesions on imaging. And so, delving more into the treatment, you mentioned steroids, but what other treatments exist for NMO and MOGAD associated optic neuritis?
So for NMO, again, the attacks are very, very severe, and so we try to treat them with corticosteroids as soon as possible. But oftentimes with NMO, we'll add on plasma exchange right off the bat. Whereas other optic neuritis that's severe, we'll do our steroids, see how they respond, and then we'll go to plasma exchange later if they don't recover. With NMO, especially if they've got a known history of it. It's IV steroids and plasma exchange just right off the bat, because we know the natural history is poor. Anywhere between 30 to 50% of those patients end up 2200 or worse. And you compare that to MOG and NMO, it's only 3%. So they're, tenfold worse in terms of outcomes. So plasma exchange early on. With MOG, they tend to be very steroid responsive, but sometimes steroid dependent. So we're going to hit them with steroids as soon as possible. And then and then we tend to do a little bit of a longer oral prednisone taper. Usually tend to do it over 6 weeks because they're, again, sometimes steroid responsive but steroid dependent. So if you just treat them with IV steroids for 5 days and then stop, sometimes a week later, they'll be coming back to the office with new inflammation, new signs of optic neuritis. So that's the short-term treatments. And then there's the long-term treatments. They're, again, very, very different. With MS, we've got some great MS disease modifying therapy. Every patient needs to be on therapy because MS tends to be relapsing remitting, and you can accumulate lab disability. We kind of briefly talked about NMO, but again, 90% of patients are going to relapse. These attacks are severe. They all have to be on chronic immunotherapy. And the good part is we actually now have 4 FDA-approved medications for NMO. So really, there's been a revolutionary in the amount of ways we can, this once fatal disease, once blind disease, we have a way of actually preventing relapses. And in MOG, for MOGAD, it's very interesting. So only 50% of patients are going to relapse. And if they do relapse, if we treat them with early steroids, they don't tend to accumulate quite so much disability. So if you have a patient with MOGAD and they recover fairly decently, we actually usually observe them initially. And if they turn out to be the 50% of patients that have relapses, then we'll treat them with chronic immunotherapy. But if they never have an attack again, we'll just watch them.
I think it's amazing that the research efforts that have been ongoing in this space has really revolutionized the treatment options. We did talk about the visual prognoses of these patients and how different it is between NMO and MOG associated optic neuritis. Uh, what about thinking about other differential diagnoses? If you do see a patient, for example, with atypical optic neuritis, apart from NMO and MOG, what else are you thinking? And what different visual prognoses are you thinking along with those diagnoses?
MOG and NMR, they're antibody-mediated associated optic neuritis, but there, could be infectious causes of optic neuritis as well. And so we always want to have things like syphilis in the back of your mind. There's a rise in syphilis. Um, Lyme disease, if they're in the endemic area, zoster, if they've got a rash in the V1 distribution. If it's more of a chronic smoldering optic neuritis that tends to be steroid responsive but very, very steroid dependent, I always have sarcoidosis on the differential diagnosis as well. So for some of these, a lot of it's kind of history. With syphilis, you often have a rash, or you have maybe some choroidal lesions that might lean that way. Obviously, Lyme, you're looking for tick bite or history of rash. Zoster be apparent. So again, it's important when you've got a patient with optic neuritis to do a full history, full physical exam, asking about rashes, insect bites, other neurologic symptoms to kind of guide you in your workup.
I think the variety of different infectious and autoimmune conditions could involve optic neuritis so much that, as you said, it really speaks to the importance of the thorough review of systems. And speaking of that, we also have another entity called perineuritis. And we know that MOG antibody associated disease can cause optic perineuritis as well, which is inflammation of the optic nerve sheath. How would you make this diagnosis, and what are some both aspects of the history or other etiologies that come to mind when you see a patient with optic perineuritis?
Yeah, with optic perineuritis, again, it's an optic inflammation of the optic nerve sheath rather than the optic nerve itself. So the vision tends to be a little bit more intact. They tend to have pain, maybe a little bit more pain. Sometimes has dyschedema, sometimes more peripheral vision loss than central. But there's a variety of ways it can present. Sometimes it can present with pretty bad vision too. In terms of differential diagnosis, now MS goes way down on the list. MOG would go up. You've got some infectious etiologies like syphilis, which can cause optic perineuritis. Um, And then a lot of optic perineuritis is still idiopathic, where we don't know the cause. And they tend to be classically in the textbook is very steroid responsive but steroid dependent. I think a lot of those classic cases were probably MOG. We just didn't know MOG at the time. So we usually treat them with steroids, and usually they get better. Want to have on the differential diagnosis would be optic nerve sheath meningioma. So that's actually a neoplastic process of a meningioma growing along the optic nerve sheath. So if you have a patient where they've got this progressive vision loss, you treat them with steroids and they don't get better, and the MRI showing this optic nerve sheath enhancement that doesn't get better, you want to have an optic nerve sheath meningioma on the differential diagnosis as well. That's typically painless. So that can help differentiate it, but I've definitely seen it mixed up there.
As you said, again, the syphilis and the sarcoidosis and MOGAD comes back again for optic perineuritis, and how it's so important to differentiate it because, as you said, the MS risk goes down significantly. I also think about GPA, granulomatosis with polyangiitis, or IgG4 disease. Other orbital inflammatory syndromes may also present with either isolated or just accompanying optic perineuritis. So I think important to keep those in mind as well.
And then another big one actually recently described is giant cellulitis. It's interesting. So giant cellulitis you would think it does cause arteritic anterior-ischemic optic neuropathy. But an MRI, if you do get an MRI in these patients, you often see optic nerve sheath enhancement that kind of extends right up to the globe, kind of in the anterior portion of the orbit. Again, usually don't need that MRI to make the diagnosis of GCA, but it can be a helpful finding if you see that.
Oh, that's very interesting. I didn't know that. And so going back to our patient who has MS-associated optic neuritis, they were amenable to getting IV steroids. And so you place them on IV methylprednisolone, and the vision still remains 20/50 with poor color vision after 5 days. Your serum demyelinating panel does come back negative for NMO and MOGAD. What would be your next step?
With 20/50 vision after just 5 days of steroids, I'd probably just give it time. The steroids quickens recovery, but it's not, you know, often just within days. Instead of recovering over 8 weeks, it might recover over 3 to 4 weeks. So I think I would just give it time. Again, it'd be different if the patient came in light perception. We treat them with 5 days of IV steroids and there's still light perception. I start getting a little uneasy. But yeah, 20/50 vision, I'd probably just give it time. But of course, need to get them plugged in neurology because we want to make sure that they start a MS disease modifying therapy. And again, there's some excellent treatments out now.
And when would you see them back in your own clinic, and how would you follow them outpatient?
Probably see them back in 4 to 6 weeks just to make sure that it's stable slash slightly improving. Assuming that looks good, I'd probably get one more final follow up in 6 months. And then at that point, just tell them about symptoms to look out for from a neuro-ophthalmology standpoint for MS. So that'd be looking for optic neuritis, double vision, which would be internuclear ophthalmoplegia or skew deviation, oscillopsia, which would be nystagmus, usually a pendulum nystagmus with MS, and then recommend just annual eye exams with any eye provider.
So let's summarize what we learned about Dr. Chen in this great episode. Optic neuritis may be isolated or related to a neurologic or systemic disorder, like we mentioned. Typical optic neuritis is associated with MS, and the classic patient is a young woman with pain with eye movement, a mild vision loss, red-green dyschromatopsia, and a central or secocentral scotoma, as in this case. And optic disc edema can be seen in 1/3 of this population, so important to keep that in mind. The majority of them do present as a retrobulbar optic neuritis. An MRI brain in orbits with and without contrast will show enhancement of areas of active demyelination and will confirm the diagnosis. We talked about the 25/50/75 rule, that the risk of developing MS in patients that the ONTT provided us. So with no lesions, 25 prior to MRI, 50. If they have a lesions, about 75% in 15 years. Treatment is with high-dose IV or oral steroids, generally methylprednisolone, 1 gram per day for 3 to 5 days, followed by a oral taper. And initiating treatment with regular dose oral prednisone is contraindicated, as the ONTT showed increased recurrences with this treatment. And then we talked about atypical optic neuritis, so a bilateral optic neuritis with severe disc edema, anyone with profound vision loss, longitudinal enhancement of the optic nerve. These are all concerning and should bring in mind other diagnoses such as NMO and MOG. These should be on the differential diagnosis for every case of optic neuritis, especially with these atypical findings. And we talked about the importance of obtaining a serum demyelinating panel for every patient, unless it's very, very classic for optic neuritis. Visual prognosis may be poor for NMO, and therefore we talked about initiating PLEX early for the acute attacks, and they do need to be on long-term immunosuppression. And we talked about how steroid responsive MOGAD is, but may need immunosuppression for recurrent disease. And finally, it's important to think about other autoimmune and infectious conditions, like we talked about in a patient with atypical optic neuritis or optic perineuritis, which are not associated with MS. Dr. Chen, anything else you would like to add?
That's a perfect summary. Again, our approach to optic neuritis is just so different now because these different entities, MS, MOGAD, and NMO, the acute treatment is different, and most importantly, the chronic treatments are different. Really, an MS medication is ineffective for NMO and MOG. We're finding now the best treatments for NMO are not effective for MOG, and so there's ongoing clinical trials for MOGAD to find the best treatment for that for chronic immunotherapy. So there's a lot of growth, but again, right now as ophthalmologists, we can make that diagnosis, get them plugged into a neurologist who's going to put them on treatments. They're going to be completely different depending on the entity. And then one more exciting thing is plasma exchange. We think it's helpful, but most of it is based on retrospective data. There's only one randomized clinical trial, and that was just pre-delayed plasma exchange. Right now, we've actually have an ongoing clinical trial we're going to start recruiting toward the end of 2025, where we're going to have 31 sites recruiting patients for severe optic neuritis, severe transverse myelitis, where we're going to either give them very early plasma exchange or delayed rescue plasma exchange to determine best timing and is it effective. So definitely keep your eyes out for those results.
That's very exciting. And I really applaud you and all of the investigators in this space to really work hard in trying to find new therapies and really guide us in an evidence-based fashion in the management of these patients. So thank you so much again. And Dr. Chen, before we end the episode, I ask all of my guests a question. And my question for you is, if you could go back in time and give your younger self one piece of advice, what would it be?
I think I would give myself two, one from personal advice and one from kind of professional advice. Professional wise, I think when I first started, I knew I wanted to do a lot of research, and I thought about a K ward, but at the time I thought a K ward you have to be 80% research, 20% clinic. And I felt starting off that just was too much research. I wanted to see these patients. I wanted to learn from them. I wanted to treat them. I want to be a better clinician. And so I chose to predominantly do clinic work and then with a little bit of research. And I've been building my research now where I'm close to 50-50. But actually now, if you're a surgical subspecialty like ophthalmology, you can do a K ward and be 50% research, 50% clinic/surgery. And again, I find that actually is a very good blend. So if I could tell myself starting career, I would have went for a K, 50% research, 50% clinic/surgery. But again, I don't think either way. That's if you want to go research, but you can be successful either way. From a personal kind of advice, again, I've got now kids who are 12 and 15. When I first started practice, they're 2 and 4. I would say I was probably workaholic for my first 5 years. I'm still kind of like a workaholic, but I've learned to carve a little bit of time for the kids because they are growing really quickly. And I think I would have spent just a little bit more time, with the kids early on. But uh, I don't think that was a mistake in any way. Just some advice to, they only grow up once.
I love those. Thank you so much for sharing both the information about the cave, but also the personal advice. I really resonate with that, and I will take that advice into heart. Dr. Chen, thank you for joining us.
Well, thanks so much. I really enjoyed it.
And thank you to our listeners. See you next time on the Pupil Pod.